Ο επόμενος ομιλητής είναι Nguyen από το Stanford, ο οποίος θα μας μιλήσει για τα top 5 commonly made mistakes in managing non-infectious uveitis. Dear Professor.
Yes, thank you. I actually wish that I would be there. I have been in Thessaloniki twice in the past and was looking forward to coming back and seeing many of the colleagues again, but suddenly the global situation has altered that plan. I certainly thank you and the organization for helping me to this meeting, and I look forward to returning in the future, very much so.
Thank you very much. Let's go.
Thank you for the wonderful hospitality in having me at the 11th Pan-Hellenic Congress of Ocular Inflammations and Infections. I would like to express my deepest gratitude to Dr. Sophia and Trudy and the organizing committee for the very kind invitations. I am very sorry that I could not join you in person as our university still imposes restriction on traveling. Today, I would like to discuss with you the top 5 mistakes commonly made in the management of non-infectious uveitis. My disclosures are listed on this slide. Let us begin with mistake number 5, continuation of similar management plans and inactivity when the patient does not respond to therapy. Let us begin with this case of a 28-year-old Caucasian man with decreased vision for several days, right worse than left. Past medical history include a 5-day severe flu-like symptoms, tonsillitis, massive headache, and back pain, especially during the night. On clinical examination, the visual acuity was 20/50 in the right eye and 20/30 in the left eye. Slit lamp examination reviewed fine endothelial precipitate and tubular cell with fibrous tissue. Fundus examination of the right eye and left eye reviewed mild edema of the optic disc, macular with glossus, and small white dot infiltrations. Fluorescein angiographies at different stages show hyperfluorescence of the optic nerve and hyperfluorescence of the various lesions throughout the posterior pole. What were the evaluations? The following evaluations were performed in this patient, including serology, as well as various laboratory testing, which show a mildly elevated CRP, C-reactive protein of 3.5, sedimentation rate of 80, the ACE and lysozyme were both normal. MRI of the brain also did not show any lesions, and so were the chest X-ray and the chest CT, none of which show any abnormality. What other evaluations and therapeutic options you may think of at this time? Continuing the clinical course, the fever persists despite being on antibiotics, including penicillin. Blood cultures were negative for bacteria and fungi. 2 weeks later, erysipelas improved on topical steroid, but the fever also improved. However, 3 weeks later, fever worsened, and so were the residual erysipelas. The infectious diseases team recommend changes in antibiotics and continued treatment and repeat blood and urine culture. At this time, do you think that the case makes sense? Does it make sense so far? At this time, we elected for our suspicion of possible and granulomatous disease. We looked at the combination of a spiral CT along with PET scan to yield a fusion images, which in this case reviewed the localization of lymph node enlargement, which were very typical for sarcoidosis. Based on the findings, the therapy was changed to oral prednisone at 1.5 mg per kilogram per tapering course. 1 week later, there was resolution of fever, resolution of the ileocyclitis, and improvement of chorioretinal lesions. What I have learned in this case is that if resolution of disease or response to therapy is not achieved, we must stop and rethink about our diagnosis and therapeutic plan. Additional diagnostic testing or procedure may be needed. Now, let us come to mistake number 4 that I have learned. Relying solely on reported laboratory testing result and not employing clinical judgment. We begin with this case of a 13-year-old Vietnamese Australian girl. 2 months prior to presentation, she developed flu-like illness lasting 3 weeks along with red left eyes. Systemic review showed no fever, chills, cough, rash, or ulcers. A lot of information were provided by Professor Peter McCluskey of Australia, with whom I share this case. On ocular examination, the visual acuity was 20/30 in the right eye and 2100 in the left eye. Examination of the anterior segment reviewed conjunctival injections, significant presence of cells and flare in the anterior chamber of both eyes with some synechia inferiorly. In the vitreous of the right eye and of the left eye, there were 1+ cell and 3+ cell respectively. Optic nerve shows significant hyperemia. Peripheral examination showed the presence of snowballs and snowbank as shown in this photograph, as well as significant amount of banking. Investigation of the case include various testing as shown. Except for the mildly elevated sedimentation rate of 45 and a C-reactive protein of 4, the rest of the examinations and testing were relatively within normal limit, except the presence of anti-nuclear antibody of 1 to 640. At that time, initial diagnosis of juvenile idiopathic arthritis associated uveitis was made. The patient was started on topical steroid and dilating agents along with prednisone and methotrexate. The patient would then continue the course. Anterior and posterior uveitis improved but did not resolve, rather they persist. At that time, we should now stop and think, does it make sense? Does the course of the patient with the suspected diagnosis along with the treatment make sense? Well, if you look back at the course again, you realize that so far the patient has not responded completely. If it were to be JA-associated uveitis, with this regimen it should have lead to a near resolution. So at this point, any different management or therapeutic regimen for this patient? What happens if we then learn that the chest X-ray showed no active disease and the MRI showed enhancement of the optic nerve left greater than right? Would that change your management? And we subsequently also learned that the patient has positive quantiferon. Important point about this case is that the clinical assessment is the basis of diagnosis in uveitis. One needs to conduct careful history and review system, perform complete ocular examination, identify correct uveitis pattern. These are the steps that one needs to take. One should also provide or conduct targeted investigation to rule in or rule out specific diagnosis and do not test superfluously. ANA has been widely ordered inappropriately in many instances, including in this case. The core that we have learned in this case is that the patient does not have JAA-associated uveitis. There's no clinical evidence to suggest lupus. The patient most likely has TB-related panuveitis. Thus, she was treated with a course of the World Health Organization anti-TB therapy, along with systemic steroid and immunomodulatory therapy, methotrexate in this case. Anterior and posterior uveitis subsequently resolved on this regimen. So the lesson that I have learned in this case is that one needs to recognize that certain laboratory testing, such as ANA, is widely ordered inappropriately. One needs to master the clinical manifestation of disease. JA-associated uveitis does not often present with snowball and snowbanks. Therefore, the finding of such entity should alert one that perhaps the diagnosis of JA-associated uveitis may not be correct, and one should not rely solely on certain laboratory values. Let us now move to mistake number 3, considering and managing a non-uveitic entity as a uveitis entity. Let's again continue with another case, this time of a 46-year-old man presented with complaints of decreased vision and blurring in May of 2014. The blurring was insidious in onset and progressive. He also complained of photopsia. Slit lamp microscopy revealed fine non-granulomatous keratoprecipitate, along with testing that show a best corrected visual acuity of 20/100 in both eyes. Indirect ophthalmoscopy and fundus ophthalmoscopy reveal no vitritis. Rather, there were bilateral serous retinal detachment that were detected, as shown by these Y arrows. Spectral domain OCT revealed the presence of serous retinal detachment with subretinal deposit as shown. In the left eye, similarly, there was serous retinal detachment with RPE irregularity and focal hyperreflective spot as shown. Fluorescein angiography in the late phase did not show significant leakage of the optic nerve or the perivasculature. Instead, it shows the various area of pooling as shown here in this photograph. Similar finding was seen in the left eye. There were areas of pooling that's consistent with the finding of serous retinal detachment. The diagnosis was made at Harada disease and was not considered to be complete VKH, and therefore the patient was started by the team at that time on prednisone 60 mg for 2 weeks, but there was not much improvement, would already give us a sign of something unusual and perhaps not correct at Harada disease, or typically quite responsive to corticosteroid therapy. Does it make sense? If it's truly Harada disease, should it have responded in some way to high dose corticosteroids such as 60 mg of prednisone? Now let's just go back and reassess the case. The patient was a diagnosis case of stage T2A metastatic melanoma since August 2010. He had undergone excision of the left shoulder lesion and 2 craniotomy followed by radiation for brain metastasis. The oncologist has initiated therapy with ipilimumab, which is an anti-CTLA-4 monoclonal antibody that has been approved for the treatment of metastatic melanoma. The therapy consists of infusions every 3 weeks for 4 doses. Based on that, we now think that in the absence of typical pinpoint leakage on fluorescein angiography suggestive of VKH or central serous chorioretinopathy, the underlying etiology for this patient was now thought to be a non-immune mediated adverse drug effect. Discussion was made and the oncologist elected to hold the fourth and final dose of ipilimumab. Oral steroids were also discontinued as it was thought that the case may be an adverse drug effect and rather than an underlying immunologic disease. Let us look through the course of this. As we mentioned, the patient first presented with 20/100 in the right eye. 1 week after the discontinuations, vision improved to 20/40 and subsequently maintained at that level. Similarly, in the left eye, after the drug ipilimumab was discontinued, the visual acuity improved along with the subretinal fluid. We share this case in a publication in 2015 as a case of ipilimumab-associated retinopathy. The lesson where we learn here is that independent and critical assessment of every clinical scenario is very critical and important. Not every case that is referred for uveitis management will actually be uveitic in nature. Therefore, one needs to start to think when the certain response, certain clinical course do not follow the pattern that we have seen. And one needs to be quite alert for other causes beyond what is being referred for us to evaluate. Let's look at mistake number 2 that I have learned: lack of attention to the details and clinical presentation. We begin these lessons with a case of a 16-year-old Cambodian American woman present with 1-day history of periorbital swelling, pain with eye movement, and decreased vision in the right eye. Past medical history include otitis media in the right ear. Social history include multiple sexual partner, and the patient had a 4-month-old child. Vital signs show mildly elevated temperature with blood pressure of 110/60. The patient was alert and oriented. On examination, visual acuity was 20/250 in the right eye and 20/20 in the left eye. There were periorbital edema and erythema. One can also see the papular lesions on the right eyelid and cheek as shown. There were chemosis and conjunctival injection with diffuse scleritis in both eyes. There were also significant anterior chamber ciliary reaction with the presence of tuberous cell and flare. In the right eye, when we look at the fundus, there were tuberous vitritis, choroidal detachment involving the macula, as well as the presence of retinal fold as shown. In the left eye, the finding was not as significant, but there were cotton wound spots and OP abnormality as shown. Additional blood evaluation for this patient reviewed a white count of 4.8 and evidence of anemia with hemoglobin of only 5.8 and hematocrit of 17%. Set rate was elevated at 140 and her electrolytes were normal. What is the next step in the management here? The patient was admitted to the hospital. She was started on broad coverage with intravenous ceftriaxone, gentamicin, and acyclovir, covering both bacteria and viral. During hospital day number 2, her urine culture grew out gram-negative rods. Fever, lid swelling, and conjunctival redness and chemosis persisted. What should one do at this time? On hospital day number 3, her anchor testing came back to be positive. The exudated retinal detachment enlarged, visual acuity dropped further to hand motion in the right eyes. At this time, a skin biopsy was performed and showed interface dermatitis with superficial perivascular mononuclear cell infiltrate. The anti-nuclear antibody was positive at 1 to 1,280. That's very high titers. Anti-double-stranded DNA was also found to be positive. At this time, the dose of intravenous metronidazole was increased to 60 milligrams twice daily. Any change in management? Anything else you would do? Does the patient have an infection? What if one put all the detail together? Facial rash, fever, leukopenia, exudative retinal detachment, presence of ANCA and ANA positivity. Could we come to a unionized diagnosis? What is the diagnosis? The blood culture was negative, the ANCA was positive, the ANA was strongly positive, anti-double-stranded DNA was positive, skin biopsy compatible with lupus, along with nephropathy and chorioretinopathy. So based on that, a diagnosis of systemic lupus erythematosus was made for the patient and appropriate therapy was started. This particular case yield many wonderful lessons that I have learned. Details, details, details. Every detail counts. Whether infectious or non-infectious etiology, symptom and signs should improve with proper treatment. Otherwise, one needs to stop and review every and all data. Finally, I'd like to share with you the top mistake that I have learned throughout the decades. That is the misconception about the safety of immunomodulatory therapy or IMT for non-infectious uveitis. Oftentimes, many colleagues think of immunomodulatory therapy or IMT with many myths. For example, IMTs are poisons, IMTs are dangerous, all IMTs will cause cancer, and you will kill your patient if you use those awful drugs. Even if the patient do not get cancer, the patient will lose all their hairs and will vomit non-stop. These are some of the comments that I have heard throughout the years from colleagues who are not familiar or do not have knowledge about IMT. In 2005, when I was in Baltimore, along with Jennifer Thorne, we published this manuscript showing the role of mycophenolate mofetil therapy for inflammatory eye disease. Mycophenolate mofetil, as we know, is an antimetabolite and one of the very commonly used IMT agents. Mycophenolate is an effective corticosteroid-sparing agent in the treatment of inflammatory eye diseases with a manageable side effect profile. John Campens and colleagues have also, through the site study, published a number of manuscripts, including the one shown here, the overall and cancer-related mortality among patients with ocular inflammation treated with immunosuppressive drugs. The site study, which includes nearly 8,000 patients or 60,802 person years, showed that the most commonly used IMT do not seem to increase overall or cancer mortality. TNF inhibitor might increase mortality, but the data are less robust and other findings. What about strong, powerful, yet may also be toxic agents such as cyclophosphamide? Here, one is paper on cyclophosphamide for ocular inflammatory diseases. We learned that cyclophosphamide is effective for the majority of patients for controlling inflammation and allowing tapering of corticosteroids. However, judicious use of cyclophosphamide appear beneficial for severe ocular inflammatory diseases where the potential vision-saving benefit outweighs the substantial potential side effects. In other words, we recognize that cyclophosphamide is a very powerful agent, yet it also has significant side effects. So we use it in a case where it's truly needed and we balance the risk and benefit. The lesson learned thus far for the IMT is that immunomodulatory therapy, when used properly, are very well tolerated by patients. The benefits of IMT in controlling inflammation and allowing tapering of corticosteroid are well demonstrated. There are small potential risks of developing malignancy are mainly from the TNF inhibitor, but supporting data is weak. In conclusion, I have shared with you the mistakes that I have learned in caring for our patient with non-infectious uveitis. The misconception about the safety of immunomodulatory therapy for non-infectious uveitis need to stop. Many of the agents that we use to manage our patient with non-infectious uveitis can be quite safe if they are used properly. Lack of attention to details and clinical presentations. Please remember that we need to pay attention to every details in managing our patient, as such details can provide us with many important clues to help us manage our patient more accurately. Considering and managing a non-uveitic entity at uveitis, please remember that often we are referred patient with a particular diagnosis. We need to keep our mind fresh as we evaluate each of these patients and not rely on the diagnosis that came with the patients. We need to look at each individual patient carefully and do not accept what has been referred to us. We can confirm just a diagnosis, but we need to prove it to ourselves. Relying solely on reported laboratory testing results and not employing clinical judgment. Please remember that we have the patient sitting right next to us who can provide us with so much information if we can just examine the patient and not solely rely on the testing result. Continuation of similar management plans and inactivity when the patient does not respond to therapy. If the patient doesn't respond to particular treatment that we have seen respond regularly in other cases, we need to consider whether we have made the right diagnosis, and therefore, if we do not think so, we should move forward to perform other testing, such as tissue biopsy, in order for us to yield a particular diagnosis that may be more proper. Thank you again for your attention and the wonderful hospitality. I look forward to the time when I can join you again in person and greet you after the pandemic has been under control worldwide. Thank you for the wonderful hospitality again.
Thank you very much for your talk. Θα ήθελα να ρωτήσω αν υπάρχουν ερωτήσεις. Thank you.
Thank you.
Bye-bye.
Bye-bye.